Welcome everyone. Today we will be exploring the processes by which we define and understand mental illness and diagnoses, and specifically how we come to know about mental illness and disorders through the process of assessment and diagnosis. First, before we get started, here's a letter that was written to elucidate how culture, time, and historical context and location can shape what we consider to be normative behavior and how that may shift over time and context. This is important to consider as we work with clients who might have experiences and come from a context that are very different from our own, namely from our Western Eurocentric context. So go ahead and pause the video for a moment so that you can look at this and explore a bit about this. So when we are thinking about mental illness and mental health, we need to recognize that they're two distinct concepts. Everyone has mental health, and this is something that needs care and proactive maintenance. We want to be sure that in our work we facilitate everyone's access to mental health, and this can require some advocacy work. Relatedly, within the concept of mental health, there is mental illness, and this is when mental health is not functioning to the degree that it's needed. So the DSM-5, the Diagnostic Statistical Manual 5, definition of a mental disorder is listed here. It's important to recognize that this definition includes consideration of social and cultural context when engaged in diagnosis. Another note I'd like to make regards the DSM's use of the language social deviance. This is a term we need to engage with carefully and consciously, as the notion of social deviance is constructed within a normative society and is constantly shifting and in need of interrogation. We'll talk a lot more about this, especially when you all take the gender and sexuality course. So if you want to pause and read this definition, please feel free to do so. So as we embark on this journey of assessment and diagnosis, we need to be aware of how symptoms that manifest could either be reactions to or responses to stimuli in life, or a mental illness. So all human emotion and behavior lies on a continuum, and this is often in response to different environmental stimuli. This is important to note as we discuss mental illness and mental health. In description of mental health, we want to be cautious in our language use, especially in our use of the word normal. This word has historically harmed many communities, resulting in stigmatization, marginalization, and violence, but it's a term often used within discussions of mental health. You might even experience clients coming in and identifying themselves or their emotions or behaviors to be abnormal. It could be key in your work to deconstruct the meaning of this word for your client. For example, to them, does normal mean that they experience no symptoms at all? Or maybe normal means that they are seeing themselves as typical or average in their mind's eye. Then again, is there a value judgment in using the word normal? Does it mean that your client is in the ideal state of functioning, or if they're classifying themselves as quote-unquote abnormal, maybe they're not? We can help them to explore the way shame and stigma are attached to this word and investigate other options for self-comparison that can lead to decreased stigma. And within this exploration is the recognition of the ways in which systems and distributions of power within society impact one's access to resiliency and resources, but can also create heightened experiences of trauma or violence in one's lived experience. So one resource that has a history of both helping but also enacting violence is the DSM. As we embark on this road of diagnosis and assessment, we must recognize both the strengths and the limitations of this system of classification of diagnoses. We know that the DSM has provided a tool for creating a common language amongst healthcare professionals and clients, helping to group symptoms and explain experiences of mental illness. Sometimes, learning that one's symptoms can be explained by a diagnosis and thus be treated in a targeted way can give many clients a sense of comfort and relief from isolation or suffering alone. There are support groups created for people with different diagnoses, and evidence-based practices created for certain disorders. However, there is a more maleficent side of the DSM. The DSM also evidences many problematic aspects due to it being created out of a specific and by a sociopolitical context. For example, we need to understand that this is a book created by a very specific group of people, and a book that originated as being designed and created by high SES, white, cis-het men with a ton of access to privilege, thus making it pretty easy to pathologize those who lived and experienced life differently. Over time, there's been advocacy to shift this manual to be less violating of marginalized groups, but there is still work to be done. So we want to ask the questions of who created the DSM, who does it serve, who does it harm, and how does societal power distribution manifest within it? This is something we'll discuss in depth in our gender and sexuality class, specifically as it pertains to the diagnosis of gender dysphoria and the gendered lens that often influences the process of diagnosis. Speaking in terms of working with diagnosis, you will often be required to explore the etiology or the underlying cause of a certain illness. There are varied belief systems regarding the etiology of mental illness, and there are theories that work to address treating mental illnesses, specifically based on the etiology or impetus for the illness's existence. There are also bioscientific approaches that rely on genes and neurochemical composition of the brain, but these must be blended with an awareness of the impact of human experience on socio and emotional learning and wellness, as well as neurochemistry and brain structure. The brain and body will react in diverse ways to diverse situations based on the diversity of the individual. In the past, mental illness was assumed to be a punishment for bad behavior or moral wrongdoing. But now we're understanding that mental illness is a combination of environmental factors like exposure to stress and trauma, brain-based disorders, and genetics. So in terms of genes, we know that genes account for about 17 to 28% of the risk of mental illness. Variations in genes linked to passing on of traits that might predispose someone to a mental illness I have the strongest linkages within disorders like schizophrenia, bipolar disorder, and ADHD. However, we also know that there are also trends of depression, anxiety, and addiction that can run in families, and thus be evidenced through genes. Additionally, the environment plays quite a large role in if or how one comes into experiencing mental illness. For example, children who are exposed to adverse experiences, especially in the formative years of their life, are more likely to experience behavior or learning issues. Some of these experiences that can create these difficulties in behavior or learning can include experiencing abuse or neglect, witnessing violence or intimate partner violence between caregivers, experience maybe a parent's own addiction or experience of mental illness, being assaulted or violated in ways, or experiencing attachment woundings. Additionally, lifestyle and access to or accessing of treatment can have an impact on the way that mental illness manifests. There's a need for holistic assessment that considers all of these pieces paired with how symptoms manifest. So, for example, the length of time, severity, impact on one's day-to-day functioning, and life. To look a little more at the levels of severity and progression of mental illness, I want to show you something that was created by Mental Health America. So this is a really neat site with assessments for people inquiring about the state of their own mental health, and it's also very accessible and has a useful frequently asked questions section. So I've included the link down here. Please explore this. There's some pretty lovely resources and assessments on there. But improvement in public awareness of mental illness has resulted from some advocacy work, specifically by this organization, Mental Health America. The advocacy work that they've done has increased public awareness of mental illness, specifically delineating how mental illness often progresses in stages. We often, when we think about representations in popular culture or when we think about clients that we might be working with, our brains can go to thinking about the most severe stage. But the purpose of increasing public awareness of these stages is to reflect that intervention can happen much earlier on if we're aware of the signs. So this is where the DSM can be very useful. It can help us to intervene in the progression of an illness before it becomes severe, and we can also then equip clients with coping mechanisms that can facilitate the maintenance and improvement of their mental health. Our clients have better prognoses or expected outcomes the earlier in these stages that we intervene. So please just take some time to explore this website. I think that you'll find some of the tools very useful, either for your own journey or for sharing with future clients. Thinking about this mental health advocacy, there is a need for advocacy and awareness within the use of diagnosis. Diagnosis needs to be taken very seriously as it can be a double-edged sword. It can bring comfort to clients and empower folks to feel like they can get appropriate information for their healing, but it can also be enabling, limiting, or stigmatizing. As we are engaging in diagnosis, we need to recognize that this is perhaps the most far-reaching and influential activity in our career. This was stated by Ben Key in 2004, and I do believe that it remains so today as we recognize that clients do receive a diagnosis that stays on their permanent mental health record. We must recognize that while diagnosis can be useful, it's also inherently flawed based on a few different factors that I'll go through here. So one, that often human information processing is rife with errors. There can be procedural or judgment errors. There can also be errors that are based on how symptoms are being presented when you are meeting with a client versus how they are showing up outside of your office. We only get a very tiny slice of the client's life in that 1 hour or 1.5 hour that we are assessing them in our office. Also, we have to be aware of the primacy effect, that we often tend to diagnose the first thing that we see. So if someone comes in and I'm experiencing low mood, maybe a lot of sadness, I might look at mood disorders, but perhaps I need to engage in differential diagnosis because perhaps there's possibly an addiction disorder there as well. We also need to be aware of the methods of payment. Codes in the DSM-5 and the ICD-10 are also billing codes. Some people argue that this book was created to have billing codes for pharmaceutical compensation, and often pharmaceutical companies were a principal part of the funding effort to revise the DSM-4 to be in the DSM-5. So, like we talk about, we need to ask who created this, who funded this. We need to have that awareness. Additionally, when clients want insurance reimbursement for their counseling, we often must provide a diagnosis with an insurance claim so that companies will reimburse. And this can be helpful to the client if they are needing that financial assistance in getting their treatment from a counselor. There also might be some government-funded programs that require a diagnosis for clients to receive services. Some diagnoses are not billable. For example, V codes are often rejected by insurance companies, so that's something to be aware of as you move forward. And additionally, diagnostic codes are not perfect. Sometimes they are uneven, overlapping, or inconsistent. They are also vulnerable to gender, racial, and social class bias. I would also say that beyond these biases, there are others, and we will talk about that throughout this program. However, diagnostic codes and the DSM are very useful, and they're necessary for our categorization for the nomenclature that can create a shared language between healthcare providers. There is an imperative call to action for us to engage in very thorough informed consent when we are working with diagnosis with our clients. Make sure that when you diagnose a client that they're aware of their diagnosis. I often like to collaborate in exploring diagnoses with clients and make sure that they're included, that included in this information is risks and benefits of diagnosis and also the caveats. So I would love for you all to just think for a bit about what are some of the benefits to diagnosis that maybe you have reviewed in the readings that we've talked about today, and then also what are some risks. This is an ongoing discussion. This has to continue past here. As an example of why we do need to be very cautious and intentional in our use of diagnosis, I would love for you all to go ahead and pause the video to review the Rosenhan experiment. Basically, this was an experiment that questioned the accuracy and the validity of diagnoses that clients received. So I'd love for you to go ahead and read through this. You can do some further research on it. It's a very interesting study, but it challenged the ways that diagnosis is fallible and that individual judgment, even though we are professionals, that our individual judgment can also be fallible because of many different interactions and contexts. So go ahead and review this, and I would love for you to ask yourself yourself, what role does bias play in diagnosis? Thinking about, like I mentioned on the slide before, socioeconomic status, racism, sexism, the gender binary, so cissexism, and heterosexism. So we need to think about a lot of these pieces and how it constructs our views of our clients and can permanently impact their health record. As you begin to dip your toes into the water of diagnosis, you might feel hesitant to do so. You will have a class in this program that specifically focuses on diagnosis, and this is going to provide a strong foundation. Be sure that you engage in active learning, critical thinking, and questioning within this coursework, as it's going to really build and strengthen that foundation from which you can jump off and start using diagnosis in your practice. However, the bulk of your diagnostic learning is going to occur in your actual practice. So as you embark on your internships and first jobs, make sure that you have strong supervision from a supervisor skilled in diagnosis. Also, based on your specific setting, you might find that the diagnoses you frequently see will vary based on your clinical population. For example, if you're working in an inpatient behavioral health setting, you might more frequently see clients with more severe suicidal ideation, self-injurious behavior, psychosis, or struggling with eating disorders. If you're maybe working with children in an outpatient facility, you might see more clients dealing with diagnoses like ADHD, autism spectrum disorder, or maybe some difficulty with attachment issues. But consultation and supervision are going to be key in ensuring that you are accurately diagnosing. As you can see on the slide, even if behavior of a client departs from the norm, it is not always pathological. Diagnosis comes into play when symptoms cause distress or impairment for your identified client. On a related note, and this will be highlighted throughout your program, when diagnosing, you must rule out other causes for symptoms. For example, if a client comes in expressing feelings of anxiety, tightness in the chest, trouble breathing, tingling in the limbs, be sure that you are going to rule out any biological causes. You will want to refer someone to a general physician for a physical before jumping to a diagnosis. The reasons why you might do this could be because this client might have a family history of heart problems or high blood pressure, something that could really be threatening to their lives. So you want to make sure that they're getting the treatment that they need and not excess treatment that they don't, or excess diagnoses that don't actually fit. So if you are referring folks out and making sure that you're ruling out any health conditions, you are going to strengthen your skills. You're going to avoid erroneously treating a serious physical health condition with your counseling skills, which we know counseling skills are not meant to treat physical health conditions, though they can help folks dealing with that. For example, management of pain, management of some like physical health diagnoses. But if you are treating someone for a mental illness when really there's a biological issue that's creating these symptoms, the etiology is biological versus mental, you are perhaps delaying proper medical treatment that the client needs. So think about this, make sure that you're referring out, make sure you're getting folks to get physicals if they are presenting with somatic symptoms that seem like they could be linked to diagnoses that are outside of our realm within the socio-emotional, psychological. And then additionally consider that certain cultural or spiritual beliefs might be impacting one's assessment of a client. There may be traditions or beliefs within a client's practice that are not of a Western context. And knowing that the DSM was created by folks in the West, a Western diagnostic manual might pathologize these individuals. So be sure that you're aware of this. And be sure to take the time to really get to know your clients and remember that consultation is key. So whether you're part of an integrated care team where you can refer someone right down the hall to a doctor, like a physical doctor, or if you have to refer out and consult with those that you refer clients to, you can offer holistic and informed care. So if nothing else, please remember, consult, consult, consult. This is going to be the key to a thriving practice and to growing confidence and competence in your assessment and diagnostic skills. Thank you.